Today we're going to talk a little bit about antimicrobial susceptibility testing. How many of y'all are doing research related to drug resistance, antimicrobial resistance, other than you? Any bacteriologists? Any infectious disease related research? A little bit here and there. Okay. So really that's going to be the focus of today is antimicrobial susceptibility testing and what the data that clinical labs provide, how you can use that data, how that data is generated, and what that data means for you and your research moving forward. So I was asked to give a brief overview about myself. I usually hate doing this, but in light of the University of Texas's amazing football season, I'll brag a little bit. So I did get a bachelor's of science in microbiology from UT Austin. And then I got another bachelor's of science in clinical laboratory science from UTL Science Center, MD Anderson in Houston. So this was a one-year program. At the end, I could sit for my medical laboratory science certification. And that's exactly what I did. So then I went and I worked as a med tech in a hospital lab for about 5 years. Got a promotion along the way to infection preventionist, moved to MD Anderson at that time, and back to MD Anderson at that time. And then worked in infection prevention for a few years. And so the two are very closely related. Everything that we generate in the hospital lab in terms of infectious related illness goes to infection prevention. And they're the ones that act upon that information on the floors and decide, does this patient need to be put on isolation precautions? Do I need to report this infection to the CDC or to the state health department, et cetera? And how do we work to prevent the spread of these infections that our lab is diagnosing? So I kind of got both ends of the spectrum. I got the lab portion, which is nitty gritty, lots of hands-on, and then I got the more personable experience talking to patients, talking with nurses, working with providers, to really make things happen in that patient care setting. So with this came a CIC, Certification in Infection Prevention and Epidemiology. I currently serve as the testing chair committee for the International Certification Board for Infection Prevention and Epidemiology. So if anyone's interested in infection control and epidemiology and how to get a career started in that field, I'm more than happy to talk to you about that as well. I then went back to school as a late bloomer in my early 30s. It's never too late to go back to school. And I got a PhD in human pathophysiology and translational medicine. So this program at UTMB, you do the first year of medical school, and then you do 3 to 4 years of research after that. So you get a PhD, there's no MD involved, but you do go through gross anatomy, physiology, you learn how to assess a patient, you kind of learn the ins and outs of what all the medical students learn the first year. So you can work with clinical teams to do good translational science. Where are the problems that they're seeing in the clinic? How do I identify those problems and do research in those areas to improve that setting? All of my research at this time was focused on vaginal infections, sexually transmitted infections, and bacterial vaginosis. So hard shift to what I'm doing now. And then COVID-19 hit about 6 months after I graduated. And I went back to work in infection prevention and control in New York City, doing consulting work for both Elmhurst Hospital and the state of New York. I then did a medical microbiology and public health fellowship at Baylor. This is a 2-year fellowship. It is the exact same fellowship that we have started here at UAB. We're accepting our first fellow this next year. If you are interested in that fellowship program, it's a clinical fellowship program, but it's geared towards DRPHs, PhDs, and some MDs, some DOs. But you need a strong microbiology background or at least some experience in infectious disease, infection control, and microbiology background. And then you can sit for your DABMM. This is a board certification that allows you to be, it's called the American Board of Medical Microbiology. So whereas your MDs sit for their board exams, this is an exam for PhDs to sit in to get board certified so they can practice as clinicians. All right. So that's enough about me. But I can answer questions if any of y'all have blossoming interests in careers in infectious disease or infection control or medical microbiology. So today we're going to talk about susceptibility testing, how we develop breakpoints. So for those of you that don't do susceptibility testing or antimicrobial resistance related infections, breakpoints are SI or R values, so susceptible, intermediate, or resistant values that are interpreted for use in the patient care world. So does this antimicrobial work against said infection? And that testing and the development of those breakpoints is how we determine that. We're going to talk about 2 different regulatory agencies. This becomes a very interesting topic anytime I talk to graduate students about their data, where they're getting their data from, what their data means, and how they should be translating that data. And then we're also going to talk about how we can use antimicrobial susceptibility testing data in a few different aspects for research, both clinical research and basic epidemiology research. So susceptibility testing, this determines a microbe's vulnerability to an antimicrobial. So I have a drug and I want to know if this drug is going to stop this bug from growing. But we have to do this using a standardized concentration of organism and a specific concentration of antimicrobial drug. So in the laboratory setting, there's 3 different ways of doing this. Our clinical lab here uses all 3 different methods, depending on what bug and what drug we're looking at. So the first one's microbroth dilution. So this is where you have a plate, like a 96 well plate, and in each well, say on a given row, there's an antimicrobial, and each well has a different concentration of that antimicrobial in doubling dilutions, going from a high concentration all the way down to nothing. And then we also put the same amount of bacteria in each well, and we assess where that organism grows. So this gives us both an interpretation and what we like to call a minimum inhibitory concentration value. So the interpretation is your SI or R value, and your MIC value would be like a value of 3. This means that an MIC of 3 micrograms per microliter or 3 micrograms per milliliter of antimicrobial was in the well that was effectively able to inhibit that amount of antimicrobial. Now there's 2 different types of microbroth dilution. There's continuous. So this is when you have a full spectrum of doubling dilutions, going from like 1 to 125 with doubling dilutions all the way. And then there's intermittent designs, which you only test short little ranges of antimicrobial dilutions. And when we do intermittent microbroth dilution, there's a variety of reasons why they do this. Most of the time it's so you can put more drugs on a single plate, but you don't get a true MIC value. You see, is it grow within this range? Does it grow within this range? And does it grow within this range? But it doesn't assess all those gaps along the way. So most of the time when it's done like this, you don't get an MIC value per se, you just still get an SI or R value. We have E-test. These are very popular. They're pretty easy to read. So the E stands for ellipsoidal, as you can tell, creates a nice ellipse. And we read it where the ellipse meets the strip. So that would be your MIC value. So these are very easy for people to read. This strip has a gradient of antimicrobial on it in a range of dilutions. And so this gives both an MIC and an interpretation. There are limitations with this. Your microbroth dilution uses a liquid media. We can adjust these liquid medias to grow almost any bacteria that we want. But the E-test can only be done on solid media, which has a lot more limitations to it. And then it's not the gold standard. So while a lot of these are FDA approved tests, we still have a lot of limitations for what drugs and what bugs we can test on these. And all of these tests need additional approval. And then we have disk diffusion. Who's seen this before in like a basic micro class? Yeah, so Kirby-Bauer testing or disc diffusion testing. So each disc in this case has a set concentration. So we're not testing a broad spectrum of concentrations here. We're testing a set concentration against a set amount of antimicrobial, and we're going to then measure how big that diffusion zone is. So using this method, we get no MIC values. We don't get a minimum inhibitory concentration that can be evaluated and adjusted based on dosing. We just get, does this antimicrobial inhibit growth or does it not? And does it do so effectively enough for us to use this drug in the clinical setting? And this is also a manual measurement, so there is some user variability with this. So antimicrobial susceptibility testing is a standardized process. I will say this is also another area where students sometimes run into trouble. I don't have this drug for this bug and I'm interested in this, so I'm just going to set this up, or I'm going to get my friend's lab to set this up for me. But the way that this is done in the clinical lab is that it's so standardized that if you change one component of it, say my friend's lab has Mueller-Hinton broth, but what they use in the clinical lab has cation adjusted Mueller-Hinton broth, you're going to get two completely different results in terms of MIC value. And that's because a lot of the standardization that is used in testing has things to do like set ion concentrations and additional supplements that do impact the way that those antimicrobials work. And so if you are missing some of those components or you add additional components, it's going to potentially change cation concentration or pH or something of that nature that's going to then impact the efficacy of that antimicrobial. And so same exact bug, in one lab it's done one way, in another lab it's done another way. You might get a value of 25 or 24 in one lab and a value of 1 in another lab, strictly based on media differences. So across clinical labs as a whole, across the country, and even in a lot of European healthcare centers, we all use the exact same process to test antimicrobials. So we use the same medium. So there's actually books, multiple volume books that go into this. And we all use the same medium to put our bacteria on. We all use the same concentration of organism. And then we all incubate under the same exact conditions to allow the most effective antimicrobial usage to occur within that given setting. We know our organisms should grow when we do it like this. And then we also get a lot of reproducibility in these situations. So we are able to get the same result for the same isolate over and over and over again. So what does the SI and R values mean? If I tell you E. coli is susceptible to ceftriaxone, what does that mean? It means it works on E. coli. No matter how much ceftriaxone I give a patient, it's going to work? Or do I still have to give a certain dosage to the patient? I still have to give a certain dosage to the patient? Okay. What if I tell you Pseudomonas is intermediate to meropenem? What does that mean? What does intermediate mean? Intermediate means that it may or may not work depending on the physiokinetics of the drug. So some drugs concentrate in certain tissues. And so if this is an area where a drug concentrates, you might still be able to use that antimicrobial. If this is not an area where that drug concentrates, it means you might not want to use that antimicrobial. Typically on the clinical spectrum, we look at intermediate as still being resistant. So a lot of times you'll see this referred to in the literature as susceptible, and then you'll see this other broad category out here that basically says non-susceptible, and intermediate falls in the non-susceptible category. All right, what does resistant mean? If I tell you this is resistant to this, yeah, it doesn't work. And so we can have acquired resistance. So this is when the organism's developed resistance and now knows how to maneuver and not respond to this antimicrobial. And we can have intrinsic resistance. So there are certain bugs and certain drugs that just never work together. And it's important for you to know the difference between acquired resistance, because that's what we talk about when we see things like superbugs in the news, and we see things like multi-drug resistant organism. And the general thought is, oh, a lot of different antimicrobials don't work against this. Yes, but this is acquired resistance, not things that we naturally know don't work against these bugs. So that S, I, and R value comes from a long range of studies. So first we have to know, before we can determine where to set those S, I, and R parameters, we have to know a couple of different things. So this is where some of my research comes in. I'm not showing you any hard data, just because I feel like these are basic concepts that everyone needs to know before we would ever dig into any hard data. But basically, we look at, like, in public health, you look at population dynamics, right? How the population as a whole is responding is a lot of times what y'all are assessing. Well, we do the same thing with bacteria and antimicrobials. So we get a whole bunch of different isolates from a whole bunch of different people and from a lot of different locations, and we test all of them against the same drug using our standard methods. And then we say, what do these population curves look like amongst these bacteria? And so that's what you see here. So our wild type population, anywhere where it says COWT, that means that's kind of the edge of our wild type population. Anything to the right of that would be considered acquired resistance, because our wild type population doesn't have that. So interestingly enough, Pseudomonas aeruginosa and gentamicin is up here. And for this bug drug combo, we see that our wild type population is right here. Sorry, I'm gonna move the big screen. However, effective dosing that we can get in the clinical setting is down here. So in this case, does it matter that our wild type population looks like this if we can never achieve this dose in the clinical lab? Or not in the clinical lab, if we can never actually achieve this dose in the patient, does it matter? Do I call all of this susceptible? This is where my wild type population is. But I can't give a person enough gentamicin to get them to that level. What does that mean? Anyone? So that means that everything is resistant. Our wild type population looks a certain way. We have a nice, beautiful wild type population curve. And generally speaking, if I could get that concentration of drug into a person, it would work. But I can't get that much drug into a person without killing them. So for all intents and purposes, that then is now resistant. So we look at the wild type distribution of the MIC values that we generate. So these create epidemiology cutoff values. We also look at PK/PD. This is when I just mentioned the whole dosing issue. Great, you have this beautiful population curve. It says this is where our wild type falls. Now, how does this antimicrobial respond when we actually put it in humans? So can I get a dose high enough in a human to get coverage for that wild type population, or can I not? So this is when we look at dosing options and how the antimicrobial distributes within the body. We also look at clinical outcomes. Okay, just because I can achieve a concentration of antimicrobial within a person, and just because my wild type population looks like it should work, doesn't mean that it's always going to work. So we want to make sure that the patients that we're treating are actually getting better. And then we look at standard conditions for accuracy and reproducibility. This is when our standardization of testing falls into play. And then from there, now we can say, this is what susceptible means. This is what intermediate means. This is what susceptible dose dependent means. So it's susceptible, but I have to change the dosing in the patient to get it to be susceptible. And then this is what resistant means. So there's a lot more that goes into what's behind a breakpoint, an SI or R value, than just a numerical number that you get from a plate in a lab. All right, so there's two different regulatory agencies that kind of oversee development of these breakpoints, changes in these breakpoints, and how this data goes from the lab setting to the clinical setting and is used and understood in patient context. So FDA, everyone knows what the FDA is, right? Would hope so. And then we have another organization called the Clinical Laboratory Standards Institute, or CLSI. So the FDA is going to kind of walk through differences in these, because all of your automated instruments that are used in the lab, you'll see them say like FDA cleared instruments can be used in clinical diagnostic testing. All of these use FDA breakpoints for the most part. The FDA will not approve an instrument if it's not using their breakpoints. So this is the federal agency that establishes breakpoints for drugs that are seeking regulatory approval. So not just the drug when a new drug comes on market, but any in vitro diagnostic test that we have. CLSI is a nonprofit that develops standards and guidelines for a wide array of laboratory testing. So they get microbiologists like myself that often investigate wild type populations of antimicrobial resistance and general populations of people. And they say, hey, we're having a meeting. Come bring your data. Let's sit down and see if we need to adjust anything. Or what have you published this last year that we need to take into consideration for our upcoming documents? So the FDA, their breakpoints are established based on data that's submitted from drug manufacturers, whereas CLSI looks at scientific literature, PK/PD principles, and also expert consensus from infectious disease physicians, pharmacists, and clinical microbiologists. So the FDA, all of their breakpoints are based on drug development studies for the most part. With the FDA, we're only updating these breakpoints in response to new drug approvals or massive post-marketing surveillance efforts, where you just have this outcry from clinicians like, you tell me I can use this drug and I keep using it and my patients keep dying. So their data and data points are not updated as often. I think 10 years is about average for the FDA to go in and review breakpoints. Whereas CLSI, this is done on a yearly basis. Every single year, they're reviewing evidence and reviewing emergent resistance patterns as published by the CDC, as published by NHSN, as published based on a random study that we might have done at UAB over the last 5 years, etc. So they're constantly looking at new evidence and emerging resistant patterns to see how these breakpoints need to shift in terms of population. And then with the FDA, they evaluate the efficacy of new agents. And so that approval process looks very different compared to what we do in the clinical lab, actually. So it's more of a backtracking to an MIC value based on dosing regimens and achievable concentrations in the patient and outcome measures. Backtracking that to an MIC value versus getting a bunch of E. coli isolates and seeing what that wild type distribution looks like, and then assessing all the other components of breakpoints. So CLSI, so CAP is part of, it's another regulatory agency that our lab here at UAB uses, and we have to be evaluated from them to get funding from CMS, basically. And so CAP now has required, hey, we don't want y'all actually using these FDA breakpoints anymore. We want you using CLSI breakpoints. So if you're ever gathering data, lots of AMR data for any research study, you want to make sure that the data that you're gathering is actually CLSI breakpoints and not FDA breakpoints, because your data is going to vary greatly depending on, in terms of how much resistant you're seeing or how much susceptibility you're seeing based on what breakpoints said institution is using. All right, and then the FDA, their data is kind of hard to find. You have to dig through their website, but CLSI is very publicly available and widely disseminated. If you actually Google CLSI free, it'll bring up a list of some of the most routinely accessed CLSI documents. Okay, so this kind of takes me into my research a little bit. Now that y'all have a lot of background for non-antimicrobial susceptibility researchers. So most of what I do outside of looking at large swaths of organism resistance, getting all the E. coli that we looked at the past year at UAB and looking at resistance patterns for that, for example. I do a lot with diagnostic and antimicrobial stewardship. And so one of the projects that I'm going to talk about a little bit later pulls antimicrobial susceptibility data to look and evaluate a population. With this, we looked at our antimicrobial data and made changes to how we were acting on that population. So with diagnostic and antimicrobial stewardship, we have a lot of information about what tests are being ordered, how they're being ordered, what data clinicians want, and how that data is being acted upon in the clinical setting. So some of those questions that we often reflect upon are, when should susceptibility testing be performed? If your doctor knows a drug is intrinsically susceptible to, or your sickness is intrinsically susceptible to a specific drug, do you want them sending out for a $500 test that you're going to get the bill for, just to tell you it's still susceptible? No, nobody wants that. So, so we want to say, should the antimicrobial testing even be performed? Should we be doing this for this bug drug combo? Should the antimicrobial be used from the source? Do you want to pay for an antimicrobial that should be used for a urinary tract infection if you have a leg wound? No. You want to only get results for the drug that's going to work against your UTI. You don't, or for your leg wound, you don't care about the results for another drug that's going to work if it's a UTI. So we look at a lot of things like that. And then we say, what are the known susceptibility or resistant patterns for this organism? Does this only have susceptible breakpoints? Is resistance even described for this organism? And then what's the cost or turnaround of a send out test? It does you no good to get results back on an infection if you're going to be done with treatment by the time you get it back, right? So, and then the other question we ask is, do we have reliable breakpoints or MIC values that correspond to treatment outcomes? So if what I'm giving the clinician is just a random drug on a random plate with a random bacteria I set up in a lab and I give them a value of 3 with no SI or R linked to that, do you think that's usable clinical data? No, not at all. And with that, it's not usable clinical data, but I'm still going to bill you for it because my lab has done it. So in looking at all of this combined, what antimicrobials should actually be reported out to clinicians and to clinical staff? And how are they going to act upon all that data? One, how is it going to affect the patient and patient billing? But also, how do clinicians respond to that? So this is where antimicrobial susceptibility cascades come into play. So you would think that anything that we set up in the lab or anything we ever did would just go into the patient's chart and all the information would be there, and the clinician goes through and in their genius ways makes the decision about what to treat the patient with. And that's simply not how this works. So there's antimicrobial stewardship guidelines and diagnostic stewardship guidelines. We kind of went over the pros and cons of that earlier, but these are core elements of the CDC. So As part of the CDC's initial initiative to fight antimicrobial resistance, they have gone to the microbiologists and said, you actually know which data is best to give to clinicians so they don't use the wrong drug, so that we don't have increasing antimicrobial resistance at the rates that we used to. And we're going to leave it up to y'all to report out what that clinician actually needs to treat the patient with. So we make those decisions here at UAB based on what drugs do our providers have access to, what's the source of the culture. Like I said earlier, if you can't use a drug on a leg, you can only use it on a UTI. Why am I giving it to you for a leg wound? And then we also address any unusual susceptibility patterns. So, hey, like normally our Pseudomonas looks like this. And this time, it's actually got the susceptibility pattern of a Providentia. Well, why is that happening? And so we can go in and investigate that as well. We look for routine susceptibility patterns. So there are general rules with antimicrobials. They kind of have first, second, third, and fourth generations. So if your first and second generations are susceptible, your third and fourth generations should be susceptible too. Same with cephalosporins and carbapenems most of the time. If your cephalosporins are susceptible, your carbapenem should be susceptible. And then tetracyclines, that class of antimicrobials, also has similar rules. This allows for us to backtrack our results in the lab, but also allows us to monitor increasing unusual antimicrobial resistance trends within our population at UAB that we might not be aware of if we weren't routinely monitoring those. And then I have BCID comparison. So BCID is our molecular test that we use in the lab. So this targets specific genes of resistance. So one thing that we can see, kind of basic microbiology and life concept, just because you have the gene doesn't always mean you produce the protein, right? So sometimes our molecular test says something's positive, but then when we go to phenotypically test it, it's not actually producing that component. So then how do you report that out to clinicians? If you're a clinician, do you want to know the genes there? Or do you only want to know how this organism is actually behaving and acting? So I'm actually going to skip ahead a little bit. So these are some examples of some cascades that we have worked out in our lab for reporting purposes. So you can see there's a lot that's involved based on the source of the infection and then whether other antimicrobials are resistant or susceptible or not. So we employed these cascade examples. When I first came to UAB, we weren't doing anything like this, but we had a really high antimicrobial usage rate, a very high antimicrobial usage rate compared to other institutions. So we worked to build these rules out and to put these processes in place so that now we were giving providers the best information possible. So I mentioned our antimicrobial usage. So this is what we call a standard antimicrobial administration ratio. It's a SAR, in other words. So this looks at all broad spectrum antimicrobials used at the institution. So going back, this was the data that I was challenged with when I got here. So a SAR of 1 means that we're using, according to the CDC and NHSN, the right amount of antimicrobial. If I'm using 1.2, it means I'm using 20% more antimicrobials than I should be using. If it's 1.5, I'm using 50% more antimicrobials than I should be using. So in June of 2023, we enacted our cascades. So you don't have to be a statistician to be able to tell me that there's a change here, right? Pretty significant change. So we enacted these cascades, and these cascades said, providers, we used to give you all this information, and you were responsible for making the decisions. And now we're literally giving you 1 or 2 drugs that you should use. Not anymore, not any less. We're giving you options. And this is what you need to treat your patient with. allergies excluded in those situations. And so we greatly reduced our antimicrobial usage at this institution just by reducing the amount of information we were giving providers and making it easier for them to prescribe the right antimicrobial in the right situation, or in some situations, no antimicrobial at all. So we wanted to dig down into this data a little bit more. So the easiest place to start and where we saw the most impactful changes happening, mostly where I was getting the most calls about why aren't you giving me all this information anymore, was related to anti-MRSA drugs or methicillin-resistant Staph aureus drugs. So we narrowed it down and we started looking at SAR data in our wards, so general hospital areas, and then our intensive care units. And we wanted to see where we were having the greatest impact. So these are control charts. I'm not sure how familiar you are with those, but basically anytime there's a hard break in the chart, that means that you've started working off of a new mean. So this would be a significant reduction or a significant increase, depending on the direction, in usage of antimicrobials. So in our wards, we had a significant reductions. In our ICU, we did not, but we do have a downward trend still, which is good and what we want to see. So, and if you'll notice on graph A, this data is in the process of being published right now. Our actual new working upper limit is consistent with our old average. So we were able to greatly reduce the amount of anti-MRSA agents we were using on the wards. So then we narrowed it down even more and we said, okay, anti-MRSA, this includes daptomycin, linezolid, vancomycin, ceftaroline, a lot of different antimicrobials. And some of these antimicrobials were hit a lot harder with our cascade than others. So where are we seeing an impact? Where was this most impactful? And what we saw consistently, at least across the wards and across some ICUs, was that all 4 drugs had been significantly impacted and significantly reduced. Some only in wards, some only in ICUs. But all 4 drugs are showing up on our chart: dapto, linezolid, ceftaroline, and vancomycin. And if you're impacted, or if you've ever been impacted by antimicrobial side effects like vancomycin can have, this is huge for an institution. If we can reduce the amount of acute kidney injuries due to excessive vancomycin usage, that's huge. But we saw a significant reduction. So we also had hit at this time less aggressively, but we had hit quite a few gram-negative related antimicrobials. So primarily our carbapenems and some of our novel cephalosporins. So what do you think novel cephalosporin means for those of you? What is a novel cephalosporin? It's what? New and expensive. And we don't see a lot of resistance to it yet. So we really, we don't see a lot of resistance. So instead of having every clinician out there throwing this drug at any gram-negative that walks in the door because they know it's going to work, we wanted to stop that because that's exactly how you get a whole lot of resistance. And so we looked at these 2 carbapenems and novel cephalosporin usage because we had really hit these were 2 other areas we had hit hard with our cascade. And so we have not done stats on this and control charts to see significant differences, but there are downward trends at least that are promising for when we do finally put this data together. So the carbapenem utilization has the downward trend, and then the novel cephalosporin utilization, if y'all can see this right here, this is huge and significant. So we went from a days of therapy. So this is how many of the days the patient received this therapy. We went from 1.5 down to less than 1. And you're never going to have negatives because you're going to have some patients that actually do need these drugs, but you do want to see those huge reductions. Okay, So I'm going to briefly touch on another area of research that I am actively involved in. And so this is evaluating novel diagnostic testing techniques for antimicrobial susceptibility testing. So most of these methods are very proprietary. These people are going, or companies are going through the FDA process of getting their instrument approved, or they've just recently gotten it approved. But general trends with them, they are using growth curves of organisms with antibiotics and without antibiotics to determine resistance instead of actually looking at growth and no growth. So everything initially is going to try to grow. Life is going to try to survive. It's just a matter of how well it actually does so. So all of these new rapid AST testing methods use phenotypic testing. So you'll still get an SIRR value. They're not looking for like a MEK-A gene. They're not looking for a carbapenem resistant gene. They're actually looking at how this bug is responding to the antimicrobial. And in our most recent study that Tyler, my researcher, has helped me with, we actually have shown that these rapid AST methods can reduce time to susceptibility results by up to 15 hours. So our current methods take about 24 to 48 hours to report out. And now using some of these newer methods, we can actually reduce that time by about 15 hours. So that's huge, especially if you're the patient on the floor waiting and wondering if you're even on the right antimicrobial that's working to treat your infection. So what are kind of the implications for this? So faster time to appropriate antimicrobial, potential sooner discharge from the hospital. Some of y'all might look at hospital population dynamics and patient turnaround times and what patients are being admitted for versus how long they're in the hospital versus when they're being discharged. And then also decrease morbidity and mortality. So one of the biggest issues with antimicrobial resistant infections is trying to figure out what antimicrobial works for this patient and how long do I have to wait to know whether I have this patient on the right antimicrobial. And that greatly impacts morbidity and mortality around these infections. So if I can get you results within 4 hours of your patient being admitted versus you having to wait 48 hours, that could literally mean life or death for the patient. So just in a general grand scheme of things, as clinical labs transition from traditional diagnostic techniques, if you are doing broad range studies, like the one we're going to talk about next that I think had a 5-year range, how do you think implementation of these rapid AST systems is going to impact your morbidity mortality study? You technically now don't have a confluent data set, right? Is that good data? Do you want to use that? What adjustments do you need to make if you were looking at this breadth of data? Okay, so this is a little example about how we were able to use antimicrobial susceptibility testing data to assess group differences. So this is part of the graduate students' work that we mentioned earlier. But one thing that I think a lot of students struggle with if you are looking at AST data is what do those numbers and metrics mean? And what adjustments should I make? What should I be taking into consideration if I do say, I want to study antimicrobial resistance? Is it as easy as going into I2B2 for the last 10 years and pulling a bunch of data and then just crunching the numbers? I guarantee you it's not. Because I think we've had 4 lab directors in the last 10 years and we all do things different. So the basic question that was asked was something like this. Is group X impacted more by drug-resistant organisms than group Y? Why do you think that this is an important question to ask in regards to susceptibility testing or in regards to antimicrobial resistance? So like how high risk? I have Joe Brown coming in with X, Y, and Z comorbidities. Do I put them on a harsher antimicrobial than I do Joe Black that has 3 different comorbidities? Or do I just treat them all like they're the same? So looking at differences in groups can identify disparities. Okay, and that's part of what this project looked at. It looked at, are there prescribing disparities within certain ethnic groups? It looks at, is there a reason? Or it can help us have to do a little more digging than just a basic question like this. But is there a reason why one population is getting more of these infections than another? And this is really translational right here. Because if you can take and say, this group gets more antimicrobial resistant infections than this other group, then it's up to your basic science and translational research to say, yeah, but why? Is there a receptor? Is there something different that we need to target? So these are critical questions to ask. And then also, it can impact clinical practice. If I know this population is much more higher risk, I'm more likely to use a different drug on them than I am other population. So for this study, it was, does diabetic African American persons have a higher rate of resistant infections than diabetic white persons? So as part of this, we have to define drug resistance. So the standard is to use these nationally recognized definitions. And if you're doing AMR data, these come from the CDC and the NHSN. WHO has their own subset, but they are very similar to CDC and NHSN. The drugs are just slightly different because a lot of countries have drugs that we don't have and vice versa. All right, time span of the study. Who thinks that this is important for a study like this? What did we talk about with FDA and CLSI earlier? How often do sometimes these antimicrobial resistance definitions changes, or do these breakpoints change? So yearly in some cases, if the data set you're working with is CLSI. So you want to make sure that you either have consistent breakpoints throughout the whole time, or that those breakpoints have been applied appropriately and consistently throughout the entire study span. All right. So were there significant changes to testing modalities and breakpoints? And then how to define infection and assess causative agents. All right, so for the purpose of this study, we looked at first-line antimicrobials because a lot of times diabetic patients are coming into their PCPs or getting admitted, and we say this is a diabetic wound infection. This is the first-line antimicrobial we're going to treat you with, and see how you respond and go from there. And sometimes plus or minus cultures. So we did a job. We defined our antimicrobial resistance definition. We looked at a steady set of time over the course of this group of individuals. And then we looked at, this is just a very small component of this study, but what the data showed was that diabetic African American patients have an increased odds of antimicrobial resistance compared to white patients, at least when it comes to first-line antimicrobials that you might want to use. So in hopes of publishing this data, it gives some indication to providers that are treating diabetic patients here. Hey, if I have a African American patient that has a diabetic wound or an infection, I'm going to maybe want to start off with a second-line agent and not a first-line agent because their risk of having resistance is so much higher. And then that's going to get that patient healed and out the door, hopefully faster. So I know I'm out of time. So just kind of in summary, I know this is a very new topic for almost everyone in this room. But antimicrobial susceptibility testing is complicated. If you're doing data in this area, don't ever make assumptions, and it's always best to not come up with your own definitions for things, and to use those standard definitions when possible. And then also be aware of technology advancements that can impact major changes in data sets. And then there's hundreds of questions you can ask that are clinically relevant or that have clinical implications. And if you're interested in antimicrobial susceptibility testing or research related to this, I'm happy to have a very extensive conversation with you because this is my bread and butter. So these are actually my bosses in the corner. But Tyler is my researcher. Angela was one of the graduate students that helped with some of the data. I do a lot with Dr. Lee and Dr. Stripling here. And then ID Pharmacy, of course. And then the Fungal Reference Lab, we contract out for some space and work when I need to do hands-on stuff.